Right. Hello. Can you all hear me and see me?
Yes, sir.
All right. Okay, good. Welcome to another session on medicine OSCE. And the first session may have been conducted by Lumal, I think, last week, and he may have given you an introduction on what sort of thing that we are expecting at the OSCE. As you know, this is a new format, and we as resource providers are also contemplating on what exactly the content to give you, and we think that this may be a mix between the past cases or the clinical examination that we had and through OSCE. So it may be a mixture of both. So that's why we are trying to incorporate all of these things into this new OSCE discussions that we have prepared for you. So as last time, I'm going to need some volunteers for the live cases, and there may be some questions on investigations, and there may be some videos. So we'll see how it goes. So each station is theoretically designed to be around 10 minutes. So there may be some for you to answer, so you can grab a piece of paper and then can jot down the answers and see how correct you are when we are doing the discussion. Right. Okay. I'm going to share my screen. Can you all see the screen? Hello. Can you all see the screen?
Yes,
Yes,
sir.
sir.
Right. Okay. Right. Okay. So, history taking, observed history taking was a clinical station in the past format where we were expected to do observed history taking, and sometimes in the previous formats you were asked some questions, but sometimes it has evolved into an observed history taking. So we think an observed history taking will be there in the OSCE, definitely in one of the four stations for medicine, and we think that there won't be any questions on that, and the examiner will judge you on how you approach the history and how you accomplish the task that you are designed to do. So for the first case, can I have a volunteer? Don't worry, it's just practice. So doesn't matter whether you get, nobody's gonna get it 100% correct. So all this is going to be marked on points, and we'll just see how you do uh, uh, in the real setup, right? Any volunteers, or I hope I don't need to point someone out. Hello, can we get one of the familiar faces to join? Either Sankar or Nipuni or hello?
Yes, sir.
Yeah. So Nipuni, right? Okay. So this is your question, right? So I'm the patient in this situation. So I'm Mr. Nimal Fonseca. I'm 50 years old. I have not been previously evaluated, and I present with shortness of breath to the medical ward. So you are the attending doctor, and you are expected to take a focus history and advise the patient on the management plan and address any concerns that I may be having. So you have 10 minutes, right? Your time starts now.
Good evening, Mr. Nimal. Can I please confirm your full name and age, please?
Yeah, I'm Mr. Nimal Fonseca. I'm 50 years old.
Uh, I am Dr. Nipuni. I am one of the doctors here in the medical ward today, and I will
Yes,
be helping you out.
yeah.
So, can I know what your preferred language is? Are you comfortable in English?
Yes. Dr. Nipuni, yes.
Okay. So, what brought you here today?
Oh, doctor, I've been feeling very short of breath. for the past month, and it seems to be worsening now, and that's why I wanted to come to the hospital to get it checked out.
Okay. So can I know what you do for work, please?
I do business, and I have a paddy field also, and I sometimes do farming.
Okay. And are you married?
Yes, doctor.
Okay. And did you complete your O levels and A levels as well?
I did my O levels. I can't exactly remember my results, and I took to business after that. Yeah.
Okay. So can you tell me a little bit more about this shortness of breath that you're having? When did
Uh,
it exactly start?
uh, Yeah, it started appearing about 1 month ago, when I used to, in the evenings, I used to go to the ground and play LA with my friends. And when I'm trying to take the run there, I have been I feel like I'm panting and I don't have the energy, and I feel very short of breath. And it has not been only and after I first noticed it when I was playing LA, but after that it had been there all the time, and when I exert it gets a little more. And now lately I don't know, I have a few stairs at my home, and I feel it like difficult to like climb about 2 stories in one go. I have to stop and then climb up again.
Okay. And did this all of a sudden start happening a month back, or did you notice it happening eventually?
Uh, well, I haven't, felt it that much before this month, but I would say like when I'm extremely exerted, I might have felt short of breath a little while back. But it started like gradually coming on during this month.
Okay. And when you do get out of breath, how long does the episode last?
Well, when it's sort of there all the time, but when I exert myself very much, and it sort of dies away after about 5-10 minutes after I rest.
Okay. And is there like when you sleep in the night, how is it?
uh in the night sometimes it gets worse, but uh, sometimes it's there all the time, but at night sometimes it gets worse, especially when it's cold, when it's raining and all that. But other than that, I haven't felt it that much at night.
Is there anything else that happens? Do you have any other symptoms that happen along with your shortness of breath? Any fever, any
No,
cough?
no fever as such. uh I cough. Yeah, cough is there a little, doctor.
Does it feel like you're wheezing?
Uh, well, at night sometimes, when it's really cold, I sometimes hear noises, but not all the time.
Okay. And what about during your sleep? Do you wake up with any shortness of breath?
No, not really, doctor. No.
So, have you been having any weight loss or any unexplained changes in your weight or anything like that?
Well, I'm a little thin anyway, doctor. I haven't like felt like I am be losing a lot. It's only been 1 month, so I haven't really checked.
Okay. And is there any other episodes like sweating in the night?
Not really, doctor. I'm from Welgama, but it's very hot there. So, yeah. So I usually sleep under the fan, and sometimes it's difficult when it's a little too cold.
Okay, and what about any other medical conditions you have? Are you on any long-term medications for any diseases?
No, doctor, no, no.
So there is no diabetes, no hypertension, nothing.
I haven't checked for those, doctor, no.
And what about any history of having the V's as a child?
No, doctor, no, not that I know of.
Okay. And what about in your family? Does anybody have diabetes or high pressure?
Device, no, I have a couple of brothers and they are okay.
Okay. Any heart problems in the
Not really,
family?
doctor, no, no.
And what about okay. And any food allergies that you know
Uh,
of?
no, no. I basically eat everything, no, nothing.
And what about any medicine that you have been allergic to in the past?
No, 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 no. I
Any
haven't,
plaster allergies?
no, 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 no.
And what about your social habits like smoking and alcohol?
Well, alcohol, we like, we used to drink, about once a week when my friends get together. And what else do you want to know?
Uh, what about smoking?
Well, I used to, I smoke, doctor, yes. That's been going on for a while. And yeah,
Okay, so around how many cigarettes a day do you smoke?
well, I used to smoke about 20 per day, doctor, but the cost is very high now. So I don't take cigarettes that much. So BD is what I used to take now. So I take about, 2, 3 rolls of BD each
And
day.
about how many years have you been smoking?
Mm, since I was a young chap, yeah, about since from my days of O levels.
Okay. Um, so what is there any other things that I haven't asked you that you would like to tell me?
Uh,
Any other concerns?
right, doctor. What do you think I'm having, doctor?
So it can be a multiple things. Since you specifically mentioned that you have been feeling short of breath when you are exercising, so it can be because of some sort of allergy that you're having some asthma, but also since you are a smoker and you have been heavily smoking, it can also be obstructive a thing called obstructive lung disease, where there is certain changes in your lungs that cause these symptoms.
Mm-hmm.
So there are a few options right now, and we can do a few tests, and afterwards, then we can find the diagnosis.
Mm-hmm. So do you think this is curable?
So that depends on what our diagnosis is, but most of the time we can manage it well with a good medication plan.
Oh, okay. So, will I be able to get back to my work pretty soon, or how long do you expect me to stay here?
So for right now, I think we will have to take some vitals and then check how your oxygen levels are and make sure that you're not acutely in any emergency state. And after that, we can proceed with taking maybe a chest X-ray and
Mm.
seeing from there. So I think,
Okay, doctor, thank you. Your time is up.
oh, thank you, sir.
Right. Okay. So, so I think last week you discussed chest pain. And shortness of breath is a very common case that you get in your clinicals or in your OSCEs. So, so you have to be like prepared for the common cases that you're gonna get because if you get it, you are expected to perform well there. and if you perform bad there, that would reflect bad upon your final score. But that is not the case in the OSCE, because all OSCEs will carry equal marks, right? Okay, so let's go through what you are expected to take in a perfect shortness of breath history, right? So whenever you are expected to take history taking or observed history taking as a component, you are expected to tick each of the big boxes, and analysis of the history of the presenting complaint would carry a vital portion of the marks. But if you have not asked the minor points or the minor boxes like allergies, social, family, travel, and those sort of things, you might lose marks rather than focusing on the history of the presenting complaint. But analysis is of course important. So whenever you take a history, you should introduce yourself, as well as you should try to get introduction of the patient, name, age, sex. The locality would have been important here. I was the one who came up with that, because some diseases may be region specific, and you may not be if you're talking about a real patient, you may be taking a history after some days patient have already been in the ward or the hospital, so the day of admission may be important. But here, because it's an observed history taking, there's a chance that you might get surrogates instead of real patients. So a patient may have some 2 or 3 presenting complaints. If that is the case, you may need to take some history regarding each of these presenting complaints. But most often, when we try to give you cases for the ERPM exam, I conducted about 2, 3, or maybe 4 exams when I was at National Hospital, and there we try to select the most simple cases, both for the history as well as for the examination. So here the chief presenting complaint is shortness of breath for 1 month, but you can have other presenting complaints there, but you need to analyze those also if the patient comes up with 2 or 3 presenting complaints. But we always advise the patient not to tell 2 or 3 presenting complaints when you're talking about the history. So in the history of the presenting complaint, you came up well. So you asked open-ended questions regarding what made you come to the hospital and let the patient describe. But some patients may not be that forthcoming, so you need to dig and ask about certain aspects. So if you're talking about patient with shortness of breath, you have to always see whether it was a sudden onset shortness of breath or a gradual onset shortness of breath, and how the shortness of breath is progressing in between, whether it's a steady thing or whether it's progressively worsening or whether it's a steady thing with exacerbations in between. So that is very important when you're assessing a history of shortness of breath. So progression of symptoms is important. So when you are talking about patient with shortness of breath, if you're talking about a progressive shortness of breath, then you have to always assess what the patient was able to do in the beginning and what the patient is able to do now. So at what level of exertion or what situations, or specifically what level of exertion will is the am I getting a shortness of breath. So here in this situation, the patient first in the first instance started getting exertion only with very severe exertion, but now is finding it difficult to climb even 2 flights of stairs. So that would mean that it's a progressive thing. So exacerbating and relieving factors are also important in any situation, pain, shortness of breath. Here, you should specifically ask about exertion, diurnal variations, whether it gets worse with cold and all the other things, and whether it's dust exposure, whether you get it at rest or whether you get it during sleeping. So these may be exacerbating and relieving factors. So whenever you are assessing a patient with shortness of breath, you should ask about associated symptoms. So here the important associated symptoms would be cough and chest pain. So if the patient has cough, you should go into the cough, like whether it's a dry cough, whether it's a moist cough. If it's a moist cough, how much sputum are you producing, and what is the color of the sputum, and what if you have a smell or something like that there. And diurnal variation is important because that is classical of asthma, but sometimes even patients with COPD may have some bronchial hyperresponsiveness, where they may have some features of asthma, such as in the patient in this situation where he gets exacerbations with cold. Okay, So differential diagnosis of shortness of breath is very wide, but you have to categorize it under main, I would say, four causes. So main four systems. So main four systems would be cardiac, respiratory, renal, and hematological. So hematological is a diagnosis of exclusion where shortness of breath is due to anemia, but the majority of cases would focus on cardiac, respiratory, and renal. So cardiac wise, whenever a patient comes with shortness of breath, you have to exclude two causes, that is cardiac failure and valvular heart disease. So patient will not get shortness of breath. uh, Chest pain may not be associated with shortness of breath. So cardiac failure, you should always ask about dyspnea on exertion. You asked about orthopnea. Maybe a better way of asking would be how many pillows do you use to sleep, who has that increased during this time. And paroxysmal nocturnal dyspnea is a maybe a more severe manifestation of orthopnea, where you can wake up from sleep, but at night it's cold, you can even wake up with asthma patients can wake up with that. Obstructive sleep apnea patients can wake up during the night. So it's not only PND, but it would suggest something like PND. And if you have heart failure, you can have right heart failure as left heart failure, but shortness of breath is usually due to left heart failure. But you can have congestive heart failure, so you should also ask about symptoms of right heart failure, like ankle and lower limb swelling if you're talking about the heart. And if you are confirmed that this is heart failure, you should always ask about any chest pain or any cardiac conditions in the family that you know. So you can get some sort of cardiomyopathies in families that can lead to heart failure. So valvular heart disease is again important. Rheumatic heart disease is still present in Sri Lanka. Like about few years back, they may have got it, but they may have residual valvular disease from that. So rheumatic fever in the past and congenital heart disease is important when you're talking about cardiac causes of shortness of breath. And again, here two other things that you was asked is intermittent palpitations, so where the patient would get arrhythmias like atrial fibrillation, and if the patient has exertional dyspnea or exertional syncope, especially in an elderly patient, that would suggest that patient may be having aortic stenosis. That may be again a cause for shortness of breath, that is exertional. So cardiac wise, cardiac failure and valvular heart disease, you need to ask some points regarding this. You asked, but this is the perfect thing, but we don't expect you to ask everything, right? You can't do that. So tick some boxes in each category. So respiratory wise, we have a wide differential diagnosis for shortness of breath. So main two diseases that you need to know, ask about in patients with, I would say four, with shortness of breath is asthma, COPD, bronchiectasis, and pulmonary fibrosis. So asthma wise, you should ask about intermittent and episodic shortness of breath where the patient is well in between exertions. So here the situation was not that patient had a baseline level of shortness of breath with some exacerbations, mainly with exertions and sometimes with night. So the history may not be classical because we are not talking about real patients and not stereotyped role players, right? So there may be diurnal variation of symptoms. There may be precipitation of symptoms with dust, cold, certain foods. And you asked about wheezing, that is very good. And patients with asthma can have associated allergic rhinitis, they can have eczema, and they can have GORD. So if you're going in the asthma pathway, you should ask about these things, but you have asked some things for that. COPD, progressive shortness of breath, which is a very high top in the list in this patient who has a very significant smoking history. So progressive shortness of breath with acute exacerbations. So the history may not be that long for this patient to have exacerbations with hospital admission, but still this could be the first presentation of COPD. So patient, what's important here is patient has a baseline shortness of breath, but this shortness of breath was progressively increasing over 1 month duration. That is not that typical of COPD. So acute exacerbations, patients you can ask about whether cough or with productive sputum, and smoking history is very important. And if you're talking about a female patient, you should always ask on what is the fuel that you use to cook, because firewood exposure is a known cause of COPD. Right. So the other two diseases that are very important in respiratory causes is bronchiectasis and interstitial lung disease. So again, if you ask about cough with huge amount of sputum, so if you tell a patient, patient tells you that they are having sputum, you should always ask on quantifying it. So it could be like yogurt cups, like coconut shell, or even maybe a bottle, or something that you're familiar with, to quantify the amount of sputum. And if the patient has sputum, again, the smell and the color are important. So hemoptysis again is important here. There are only few causes of hemoptysis like bronchiectasis, TB, and bronchial malignancy. So if you're talking about bronchiectasis, you should always ask about any past history of TB or any chronic cough, respiratory tract infections in childhood. You asked about that. And in an asthma patient, you should always, having bronchiectasis, you should think about this indication called allergic bronchopulmonary aspergillosis, but that we don't expect you to ask in this 10-minute observed history taking. So interstitial lung disease is a very important component here because the patient owns some paddy fields and patient may be exposed to hay, where the patient can have hypersensitivity pneumonitis. So that is seen in paddy fields when you deal with hay a lot. So ILDs can progress very rapidly in a limited amount of time. So ILD is a very important diagnosis here, and smoking also can cause ILD. So ILD or COPD in a background COPD patient is the likely diagnosis here, depending on what I explained. But we don't expect you to come to that diagnosis because the history was not stereotypical. So in ILDs, you can get progressively worsening shortness of breath. And if you have a cough, it's usually dry cough. You do not get a lot of sputum in patients with ILD. So if you think ILD, you should always ask about etiology of ILD. So connective tissue diseases is important. You can ask about joint pain, skin rashes. So this is a very important question in most of the histories that you are going to get. Just ask about some features of connective tissue disease to show that you have thought about that. Right. So occupational exposures are important. Long-term drugs like methotrexate, if the patient is having rheumatoid arthritis, is important. And exposure to birds and hay, and of course sarcoidosis if you're talking about red dyes and if you're brilliant, but I don't expect you to come out with this in this instance, right? So there are also other respiratory causes of uh, shortness of breath. Like if you are immunocompromised, opportunistic infections can give rise to this. So you could have asked about this because patient was smoking, and if you had asked more, I would have told you that I am consuming ganja and I have had some other partners and all that, right? So this could have been an important uh, factor in this patient. So bronchial malignancies are important. Again, you should think, you asked about your constitutional symptoms like loss of appetite and loss of weight, which are not there. And an alteration of character of voice can happen with your recurrent laryngeal nerve involvement. Hemoptysis can also suggest that patient is having pulmonary vascular disease like vasculitis, or a patient can have concomitant renal involvement with that, where you can ask about body swelling. And if you're talking about especially a female, you can think about pulmonary hypertension as a cause of shortness of breath. And you can ask about history of recurrent thrombosis or pregnancy losses. So again, these are minor points, but you know, can carry some marks if there are marks allocated for that. But if you ask about bronchiectasis, ILD, asthma, and COPD, that too would have been enough. So the other main cause would be renal disease causing shortness of breath. For that, there should be significant renal impairment with fluid retention in the body. So there should be episodic shortness of breath with uremic features like itching, nausea, vomiting. Neurological disease causing shortness of breath is very rare. If so, patients should have obvious muscle weakness in the other muscle groups. And finally, anemia as a cause of shortness of breath is a diagnosis of exclusion. So if you have excluded all the other things only, you should think about anemia. Here you can ask about lethargy, malaise, and all that. So fatigue can be a common complaint in patients with anemia, but fatigue can be due to a lot of things. And sometimes patient if they, even if they say shortness of breath, they could mean fatigue by that. So you should clarify whether you're talking about fatigue or shortness of breath when the patient comes up with shortness of breath, right? Okay, so this is the history of the presenting complaint, and you should always ask about, in any patient, what has been done up to now and the investigations and the treatment done. So ECGs, in this case, X-rays, maybe echoes, blood investigations, whether the patient was nebulized, whether the patient was given in oxygen therapy, inhalers. But now this is the first presentation, so that this maybe have been done before coming to the hospital, maybe at a GP level or in another institution. So that is also another important component in the history of the presenting complaint. So in the history of the presenting complaint, you analyze the symptoms, you try to get at the etiology, you try to get at the complications, and you try to see what has been done for the patient up to now. And you should always assess the current functional status of the patient if the patient is having a progressive illness. So other diseases you asked, so past medical history we have ticked. So diabetes, hypertension, dyslipidemia, ischemic heart disease is very common. So it may be related or not related to your history. So here, things like hypertensive heart failure, diabetic cardiomyopathy, or ischemic heart disease because of these vascular risk factors leading to cardiac failure would have been important if I had those risk factors. But if the patient has tells you that they have that disease, you should just get some information on how long, what are the complications, what are the drugs, and how is the control. At least those little things. So past surgical history may not be relevant in most cases, but you will get a point for asking about that. So, and you ask specifically about allergies. So you can just go in one sentence, do you have any drug, food, or blast allergies? That would just finish it up, right? Rather than wasting time on each component separately, right? Because you will only get some very small mark on asking about the allergies. When if you're talking about females, because not important here, but you should always focus on whether you are menstruating regularly, whether you are menopaused, and if you have unobstetrics, how many children do you have, any pregnancy losses, and all that, right? And sexual history is important again here because of the immunocompromised status, so active or not, whether the patient has fertility plans and contraception if the patient is especially a female. If you are talking about very bad diseases that would impact the patient's management and future decision making. Erectile dysfunction again will be important, for especially talking about patients with diabetes. So you asked about family history of chronic illnesses or malignancy, which may be important here because some cancers may run in families and even cardiomyopathies can run in families. So travel history is important because we are talking about a possible respiratory illness where, travel abroad, he may have contracted COVID or the SARS, MERS, and all these other viruses that could have precipitated that. So that is important here. And dietary history may not be that important, uh, may be important for cardiovascular risk factors, right? So personal history is important, sleep, smoking, cigarettes, cigars, BD, how many pack years, and as I told you that I have smoking, you are expected to, state the patient, make a statement that this may be contributing to your illness and you should think about stopping smoking or you should stop smoking, right? So if you tell that to 10 patients, either one patient will stop, right? So that is expected from you both at the exam level and when you're practicing, right? So if your patient tells you that patient has a substance behavior, you should ask about the substance behavior a little. How much, how often, what is your behavior? Who do you smoke with? Who do you take alcohol with? Do you think that you should stop? And have you tried stopping earlier, right? So whether you are dependent on that or not, you should assess, especially if you're having alcohol and also smoking. Social history, you asked about this O levels and A levels, and a better way of asking is uh, uh, up to what level have you been educated up to, or something like that, right? So job and income is important because patient may need to afford some treatments, and you can have an idea about the background. So details of family again may be important, right? If you had asked, I would have told you that I've been living separately from my wife, right? Okay. Right. So impact of disease is important because most of the time we are talking about chronic diseases. So how the disease affected my activities of daily living. So I have been severely affected because I cannot climb upstairs, I cannot play with my friends or go to work. And I have been absent from work because of this, my businesses and all that. My family life is compromised and I am depressed and I'm mentally down because of that. So that is important. So home environment is very important in a patient with shortness of breath. You should ask about the cleanliness, ventilation, sunlight exposure, what the roofing is, whether you have any pets, especially furry animals and pigeons and birds reared at home again maybe important in hypersensitivity pneumonitis, and how many stairs that you have at home where your ADLs may be affected because of that. Nearest hospital and mode of access is important, and ICE you didn't go that much into, but I came up with that and you answered uh, quite well for that. But you are expected to ask that questions, right? Uh, you know, what are your concerns? Just some statement like that, and then the exam patient or the surrogate will help you on that, right? So you see, it's a very extensive process, and you should always, uh, write the judge if you have time before the station, like 1 minute to prepare, if you think so, but probably it will not be the case. So first, whenever you go, you jot down what you're going to ask, then tick, 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 and then focus much on the history of the presenting complaint, right? And that is how it goes. So shortness of breath, very important. So once you can go through this again and see what are the points that you missed and how you are going to take it better the next time, right? Okay, so enough talking. We have a question like this, right? Right, so this is a cardiovascular system examination where you are expected to find a murmur. And if you get a case for cardiovascular system examination, we think it may be a real patient, but not a simulated murmur like this. And you should be able to identify and listen to the murmur and identify and then go on answering the question. So probably it will not be examiner based questions. It will be a list of questions depending on what you find in the examination, right? Okay, so can you hear this? Yes. Okay, so you can keep listening to that and answer these questions.
So can you play it again?
It's playing. Still playing, right?
We
No.
can't hear it.
All right. Okay, how about now? No.
You
It's
just
just
hear one single sound in the beginning, but nothing else after that.
All right. Okay, it. Can you hear it now? No.
Also,
How about now?
no, sir.
No. Okay.
So if you can like share that audio file on WhatsApp, we can all listen to it. So even Dr. Lumal had this issue last time.
Okay. So it has come as a video, so you can, only the sound is there, right? Do you have it now? No?
We received it.
All right, okay. Right. So just think about what that memory is and what are gonna answer for these questions, right? I'll give you about 2-3 minutes for you to think, but you would, because there's a lot of questions, you'd get at least 5-10 minutes, 5 minutes for answering the questions and 5 minutes for possibly examining the patient. Okay, we'll see in about 1 minute. All right, so if you haven't guessed what the murmur is, it will be difficult to answer the rest of the questions. Right. Okay, so cardiovascular system examination is a very common thing. So up to the format that we had now, we uh, took patients from all the four systems, and you were expected to examine only two systems. So it's very likely that you will get a patient with examination for one out of the four OSCE stations that you have, or maybe it could be even two. So again, you have to be very thorough because the cardiovascular system examination, because that's a very common murmurs we find very commonly, and the respiratory system examination, right, out of the neurology and abdomen. But depending on the cases for the day only, we would give on the most simple cases to you all. So the murmur that you heard was of aortic regurgitation. So if you listen very carefully, you'll first hear the first dart sound, and along with the second dart sound, you will hear this murmur. The second dart sound is not audible in this patient. So first dart sound, along with the second dart sound, you will see the like murmur, which is classical of aortic regurgitation. It will not be harsh because it's a diastolic murmur, but when it's a very large aortic regurgitation, sometimes the murmur may be harsh. Right. So in the cardiovascular system examination, if you are told to examine a patient, you should expected to do the general examination, where you go from head to toe. You check for febrile, you check for pallor. Icterus is not that important in cardiovascular system examination. Then you look at the lips and inside the mouth to see for cyanosis. Again, cyanotic heart diseases we very rarely give for you all, so most often not. So you can even forget about cyanosis, and you can check for dental caries, but that is again not that important. Most of us have a very poor dental hygiene. And then going down, you are looking at in the hand specifically, you are looking for clubbing, and in the legs you are looking for ankle edema, that is pitting just 2-3 centimeters above the medial malleolus. You press for 5 seconds, 1 and 2 and 3 and 4 and 5, and then release and see whether you are getting a pitting edema. And of course, when you're pressing on the patient, you should always look at the patient's face, because if you cause discomfort, that would cause you negative points. And from the legs upwards, you can check for the dorsal pulses, dorsalis pedis, and maybe the posterior tibial. If they are there, no need of checking the other peripheral pulses. And then you move on to the pulse examination, where you are expected to see the rate, rhythm, character, check for radio-radial delay, radio-femoral delay. Then you ask for the blood pressure. Then you check, you have a look at the JVP, and then you move on to the precordium, where you do the uh, inspection, palpation, and auscultation in cardiovascular system examination. So what is specific we look for in a patient with aortic regurgitation? So aortic regurgitation, you may get a hint on what the cause of aortic regurgitation is. So what we are looking for is a marphonoid habitus in a patient who is very tall, who's having very long arm span, and when you look inside the mouth, sometimes you may see a very high arched palate. And because most of the patients will be lying down, you may not be able to see a stoop rigid back, which you may see in patients with ankylosing spondylitis who can also have aortic regurgitation. So specifically in aortic regurgitation or any patient with uh, uh, cardiovascular system murmur, you look for fever, because fever may suggest that the patient may be having infective endocarditis, and you should always look at uh, uh, the bed, the foot end of the bed, to see whether there's a fever chart, because sometimes the patient may not be having fever now, but the patient may have had fever within the past few days. So pallor is again important in a patient with cardiovascular system examination, because pallor can worsen, anemia can worsen heart failure, or could be anemia could be a consequence of long-standing infective endocarditis. Clubbing is again important. Only two conditions in cardiovascular system examination you get clubbing, that is infective endocarditis and cyanotic heart disease. So because we are not giving you cyanotic heart disease, if you see clubbing, it's most likely infective endocarditis. But if you see clubbing, don't go to mention about the degrees of clubbing and all that, because that is not relevant, right? Then they will, if you are, the examiners are asking you, they will ask about what are the degrees of clubbing and all that, and then you will get stuck. So just say clubbing or no clubbing, that's it. And in looking at the pulses, you should always look at the neck. And in aortic regurgitation, you see visible carotid pulsations because of the high volume circulation in the patient. So pulse wise, you have a high volume collapsing pulse, and without any radial or radiofemoral delay, and you are expected to check for the collapsing pulse in these patients, where you take the arm and you keep your fingers very lightly until you just feel the pulse, and then you always ask whether you have a pain somewhere here, and then support from here and lift the arm up to see whether your pulse will collapse and cause a bounding nature, that would suggest that there's a collapsing pulse. Again, collapsing pulse is not specific for aortic regurgitation, but would suggest aortic regurgitation in the presence of a suggestive murmur. Blood pressure wise, when you ask for the blood pressure, sometimes the blood pressure may be given, recorded. You should always see the pulse pressure in these patients, and the pulse pressure may give you a hint that patient may be having aortic regurgitation, where the difference between the systolic and the diastolic may be more or equal to the diastolic pressure. Moving on to the precordial examination, sometimes if they have a very high volume circulation, if the patient is thin, you may be able to see a visible apex beat in these patients. And if you were trying to palpate for the apex here, you will see a displaced apex. So if you have a displaced apex in a patient with cardiovascular system examination, that would suggest that the patient is in volume overload, and patient should have either of mitral regurgitation or aortic regurgitation. And sometimes you can get patients who are having mixed valve diseases, where patients can have two diseases of the same valve. They can have AR and AS, they can have MS and MR. And if you have a displaced apex that is forceful, we call it as a thrusting apex, or maybe a displaced forceful apex, that would suggest that this patient is having significant volume overload, and the regurgitant murmur is the predominant component here. So sometimes when you have long-standing heart diseases, you can have pulmonary hypertension, and you can see a palpable second heart sound. So when you're always, if you're presenting, probably not in the OSCE, but when you're presenting to someone else, you should always tell about the character and intensity of the two heart sounds. So what's important in aortic regurgitation is that you have a soft second heart sound. So even if you get pulmonary hypertension, it may not be that loud. So murmur, again here as we described, is a very high pitched early diastolic murmur. So this is different from the mitral stenosis murmur that you hear most in the apex, that is comes after the second heart sound. So here you are not able to hear the second heart sound separately from the murmur. So you should train your ears very well, and then keep listening to AR and MS to try to differentiate these two. Right, so it's best heard in the mid or lower left sternal edge. So there are some maneuvers that you are expected to do in a patient when you're doing cardiovascular system examination. That is the maneuver for mitral stenosis and maneuver for aortic regurgitation. So in mitral stenosis, you turn the patient to the left lateral side, keep the bell, and ask the patient to take a deep breath in, put it out and keep holding the breath in expiration to see whether the murmur will exacerbate in expiration when the patient is in the left lateral position. So in aortic regurgitation, you keep the stethoscope here here in the left lower sternal edge. You ask the patient to bend forward and take a deep breath in, put it out, hold it in expiration. So you can tell something like Honda husmak aragana, Eliata dala, navattaganin, something like that. So would be a good command, and you can hear that the murmur will exacerbate. So these two maneuvers you are expected to do in any patient with cardiovascular system examinations, because we are assessing on how you are doing those two maneuvers. So in patients with severe aortic regurgitation, there may be a lot of blood going back into the left ventricle, and that blood may go into the left atrium, and you may have a lot of blood coming into the left ventricle when it is being filled. So you can hear a murmur that is similar to mitral stenosis in patients with severe aortic regurgitation. That is known as an Austin Flint murmur. So if you hear two murmurs in a patient with aortic regurgitation, this could be an Austin Flint murmur. So the question I have asked is, what is the cause if it's an acute presentation? So infective endocarditis is the topmost thing that you have to exclude in any patient with an acute onset murmur. So IE would be, correct across all fields if it's an acute presentation. But aortic dissection can cause acute aortic regurgitation, and a condition known as ruptured sinus of Valsalva can also cause acute aortic dissection. Chronically, you can have infective endocarditis or rheumatic fever causing aortic regurgitation, and other cause of aortitis or aortic inflammation like Takayasu arteritis, ankylosing spondylitis, connective tissue disorders, and collagen disorders like Marfan. Oh, it says Marian, right? Okay, correct that later. So it's Marfan, and Ehlers-Danlos can also cause. So just have an idea on. So definitely you'll get asked on the etiology of the murmur, right? So whenever you're describing a murmur, you have to say that this is where I heard the murmur. This is most in inspiration or expiration. Timing was this systolic or diastolic, and I think this is this murmur, and etiology probably is this, and it is not complicated like this. So etiology and complications is a must when you are giving out the diagnosis of a cardiovascular system examination station. Right. So peripheral signs of AR, there are about 20. You are not expected to know everything, but you should have a look at some of these things. So one we already checked, that is the visible carotid pulsations, that is the Corrigan sign. You can sometimes get head nodding. This is called the Musset sign, and when you are doing the oral hygiene, you can check the uvula to see whether it's pulsating. You can sometimes have that, and nail bed capillary pulsations are also may be seen in severe AR. And you can have this sign called pistol shot femorals or the Traub sign, and when you place your bell lightly on the femoral artery, and when you compress it distally, you may hear a diastolic bruit over that your bell, and when you compress it proximally, you may hear a systolic bruit over the bell. So that is known as the Duroseus sign. So just keep an eye on about two or three of these things, because you will definitely get asked on what are the peripheral signs you look for if you get a patient with aortic regurgitation. So clinical severity wise, again, there are some points that are salient for most of these murmurs. So presence of pulmonary hypertension and presence of heart failure would say that the patient is having a very severe murmur. But specific to aortic regurgitation, if you have a wide pulse pressure, if you have a longer murmur, and if you have an Austin Flint murmur, and sometimes you can get a third heart sound, that would suggest that the patient is having severe aortic regurgitation. But if you are not sure on what are these are, so just say pulmonary hypertension or write pulmonary hypertension or heart failure. If you can't remember the exact things, they may carry some marks, right? So complications. So what are the complications that you are going to assess in any patient with any cardiac murmur? You basically assess for uh, three complications. That is heart failure, pulmonary hypertension, and infective endocarditis. So those are the main three. But again, in any murmur, you can get arrhythmias and you can get sudden cardiac deaths because of arrhythmias. So those are the complications that you expect. But those three are the things that you should mention and write when you are asked on complications of any murmur. So the next question on what are the investigations that you're going to do. So in any murmur, the investigations that you're going to do is an echo for confirmation, and you can look at some other things like the anatomy of the valve, the pressure gradient, the regurgitant volume fraction, and the LV dilatation. ECG you can mention, and chest X-ray. So ECG, chest X-ray, and echo would be good enough for most cardiac murmurs if you are asked on the investigations that you are going to do. But make sure to mention the echo first, because we really don't keep prevent from doing echoes, because echoes are widely available now. So there's no need of like going into the diagnosis from ECGs and X-rays, but you are expected to mention those as well. So coronary angiograms again may be important if you're thinking of ischemic heart disease as a cause for aortic regurgitation. So management wise, in any patient with any valvular disease, you can do medical management, be it loop diuretics, control of blood pressure, control of heart rate and all that. But most often it will be surgical management. So you have to know what sort of patients you want for surgical management. And in aortic regurgitation, if you have symptoms, you should have surgical intervention. If you don't have symptoms, you should have surgical intervention if you have heart failure, if you have a very big aortic root, and if you have a left ventricular dilatation. So it's pretty easy to remember, right? So here we have some different methods of valve replacement. You can do an open heart surgery where you put a valve inside, and you can do a minimally invasive valve replacement, or TAVIs or TAVRs, which are done via putting the valve through a catheter from by like how you do the PCI. So again, uh, that is a common question if you asked about aortic valve replacement, both in aortic stenosis and aortic regurgitation. If you do a valve replacement, patient should be on lifelong anticoagulation. Right. 10:39. Okay. Right. So next station would be a neurological station. Right. So can you see this video being played? Right. Can you see that? Yeah.
Yes.
Okay. So there's no sound here. So you can see the video and answer the questions. Right. We'll give you about 5 minutes, but in reality, you will get 10 minutes. Right. Okay. So what is there?
So facial nerve paralysis.
Okay. So this patient is having left-sided lower motor neuron type facial nerve palsy. That is the thing that you can derive from this video, right? So here they are pointing towards how the angle of the mouth is shifted towards the right side, and here the nasolabial fold is lost on the left side, and when the patient tries to close the eyes, this eye go up. That is known as the Bell's phenomenon. That is a natural process. Whenever you try to close your eye, your eyeball will roll up, and they will ask you to wrinkle the eyebrow. So here you don't see wrinkles on this side. That is how you differentiate between a upper motor neuron facial nerve palsy and a lower motor neuron facial nerve palsy. So upper motor neuron would mean that the lesion is above the facial nerve nucleus. So facial nerve nucleus is in the pons. So anywhere above the pons you can have the lesion. And if you have a lower motor neuron lesion like this, where the wrinkles are lost on the affected side, that would suggest that this is a lower motor neuron lesion, which would mean that the lesion is at the pons or down below the pons, anywhere along the tract of the facial nerve. So here again, they are trying to check, asking the patient to puff up the cheeks to see whether the air is escaping from that side, and asking the patient to do a whistle and see whether the air is escaping from that side, and also asking the patient to tightly close the eyes and uh, allow not to open. Again, it's affected on that side, and here asking the patient to clench their neck muscles, that is the platysma, to see that clenching is not present in this side, right? So neurology wise, sometimes most often, if you are asked to examine the cranial nerves, you may be asked to examine either the upper cranial nerves, the lower cranial nerves, and sometimes even the motor cranial nerves. So these may be the three commands that you may be given if you are expected to examine the cranial nerves. Sometimes you may be asked to examine the eyes again, which will be very rare because we give very simple cases to you. So lower cranial nerves would mean 7, 8, 9, 10, 11, 12. Upper would mean 1 to 6. So
have you noticed any change in your
can
sense of
you
taste
hear
or
this? No? Oh, yes.
Yes.
hearing?
Yes, sir.
Okay. Right. So I'll mute the volume so that I can speak. So whenever you are doing this lower cranial nerve examination, you are not expected to speak to the patient, unlike in these videos. But if you're expected to speak, you can ask about a change to sense of taste or hearing. And it to start with the facial nerve, where you ask the patient to wrinkle, ask the patient to tightly close, and see here for the nasolabial folds and the angle of the mouth. So you can inspect for facial asymmetry, where you can see a Bell's palsy on the right side. And then you check for the 5 branches of the facial nerve: zygomatic, uh, yeah, uh, temporal, zygomatic, buccal, marginal mandibular, and the uh, yeah, and the cervical branch of the facial nerve. The 5 branches of the facial nerve would examine. So ask the patient to raise the eyes, close tightly the eyes, blow out the cheeks, smile, and purse your lips, like that. Then you check for the eighth nerve, then you can perform a gross hearing test. So here you do something known as masking of the other ear, and you whisper a number in that ear where you are, the patient is expected to tell what the number is. So if you, because we are not doing the Vibers and the Renes, you are not expected to do that. So you can maybe ask for 2 or 3 numbers to see whether the patient can actually hear those numbers. So this is how you do the Rene. You do a 512 fork and you keep it on the uh, mastoid process, and when you finish hearing it, you see whether the patient has good air conduction by asking the patient can hear it. Then you perform the Vibers by vibrating the tuning fork and keep it in the middle and asking whether you feel it in the middle or whether you feel it in the right or the left ear move. And you don't usually check for this Unterberg test where you check for the vestibular part of the vestibulocochlear nerve to see whether the patient has good balance. So then you ask, check for the cranial nerves 9 and 10. If you can speak, you can ask about difficulty in swallowing or in the voice, but you don't do that much. And then you can see the patient's uvula. So you can ask the patient to say ah, and if you have a 10th cranial nerve lesion, the uvula will pull the muscle up like this. So if you have paralysis on this side, that would suggest that the uvula will move to this side. So the uvula will deviate away from the lesion. So if you have paralysis on this side, this uvula will move to that side, and there may be asymmetrical deviation of the soft palate. So here it moves in the middle, right? And you can ask the patient to cough. Maybe a weak cough would suggest a vagus nerve lesion, and maybe take a sip of water, but we don't perform that much. So checking the uvula itself may be enough. You don't check for the gag reflex anyway in the exam. You can have to check that using a tongue depressor, and you can check for the accessory nerve. So the 11th nerve will innervate your trapezius and the sternocleidomastoid, and you can check for that by asking the patient to shrug your shoulders like this. And then you ask the patient to turn the cheek to this side. That would suggest that this sternocleidomastoid is functioning well. Turn into that side. That would suggest this sternocleidomastoid is functioning well. Finally, you check for the hypoglossal nerve. You check for the tongue wasting and fasciculations like that, and then you ask the patient to protrude the tongue out. So this side of the tongue will protrude the tongue like this. This side of the tongue will protrude the tongue like that. So when both muscles are functioning well, the tongue will be put out in the center. So if this side is paralyzed, this side will be more active and it will pull the tongue like this. So the tongue will deviate towards the side of the lesion. So the tongue will deviate towards the side of the lesion, and the uvula will deviate away from the lesion. So that is how you check for cranial nerve 12. You can also check for the tongue strength by doing something like this. So, and finally, you have to thank the patient and wash the hands. So that's how you perform the lower cranial nerve examination. You inspect the face, check for the 5 branches of uh, the facial nerve, the temporal zygomatic, the buccal, marginal mandibular, and the cervical branch. And then you check for the crude hearing assessment, that is the vestibulocochlear. Then you directly check inside the mouth to say ah and see the uvula moving. And then you can maybe check the 12 from there itself, see the tongue wasting fasciculation, and ask the patient to put the tongue out, and finally check for the trapezius and sternocleidomastoid. So you go in a particular order, practice one order, and do in that order that you are not going to miss, right? So facial nerve is very important because it's one of the 2 nerves that has a unilateral innervation out of the cranial nerve nucleus. The other nerve that has unilateral innervation is the hypoglossal nerve. All other cranial nerves will have bilateral innervation from both cerebral hemispheres. So the cranial nerve nucleus, the facial nerve nucleus has 2 parts, the upper part and the lower part. The lower part will supply the lower portion of the face, and the upper part will supply the upper portion of the face. So the upper part of the nucleus will get innervation from both cerebral hemispheres. So if you have upper motor neuron type uh, facial nerve palsy like here, this innervation will be cut off, but this innervation will be there. So the forehead wrinkles will be preserved. But if you have a lower motor neuron lesion, that would mean that the nucleus or somewhere in the facial nerve is the lesion. So both of these fibers will get affected and you will lose the forehead wrinkles. So looking for the forehead wrinkles is how you differentiate between a upper motor neuron lesion and a lower motor neuron facial lesion. Is that clear?
Yes, sir.
Right. Okay, so upper motor neuron lesions, facial nerve lesions are very rare. We don't usually give this to you. We want only a lower motor neuron facial nerve lesions. To localize where the lesion is, you have to know the facial nerve anatomy, right? So the facial nerve nucleus is in the pons like this, and the facial nerve, the motor part will, the fibers will go and curve around the sixth nerve nucleus. So the 7 and 6, if they are both affected, that would suggest that the lesion is somewhere here. And here you also have the cerebellar peduncle and you have the corticospinal tract. So if you have a lesion somewhere here, that would suggest your 7 is involved, 6 is involved, cerebellum is involved, and corticospinal tracts are involved, right? So after the facial nerve leaves from here, it goes very close to your CP angle. Again, your cranial nerve 5, your cranial cerebellar lesion, cerebellum is very close there. So 5 and 7 along with cerebellar signs would suggest that this is a cerebellopontine angle tumor. So the facial nerve nucleus is in the pons, it will exit there, go near the cerebellopontine angle and enter the internal acoustic meatus where it is very close with the eighth nerve. So 7 and 8 both gone together would mean that the lesion is likely in the internal auditory meatus. So inside the internal auditory meatus, facial nerve has a lot of branches and canals, so it comes and goes to the geniculate ganglion. At the geniculate ganglion, it will give off this greater petrosal nerve that is responsible for your lacrimation and all that, and then it will go further down and it will give off the nerve to stapedius where that is responsible for dampening your vibrations, and that if that nerve is gone, you will have a lot of hyperacusis. And then that gives off this coda tympani branch that is responsible for taste in your anterior two-thirds of the tongue. And after that it will go off and exit your skull through the stylomastoid foramen, where it can give us some other branches like your posterior auricular branches that control your ear movements, and then you have some other muscles known as digastric posterior belly and stylohyoid, and it will enter your parotid gland. So within the parotid gland it will break off into the 5 branches and keep innervating those 5 branches. So this is a very long tract and lot of places where it can get damaged, and you need to localize where the lesion is if the patient is having a lower motor neuron facial nerve nucleus, that would facial nerve palsy, that would suggest the lesion is somewhere here. Right, so how do you do that? So when unilateral, although you are asked to examine the lower cranial nerves, and if you find that the patient is having a seventh nerve palsy, you should always examine the fifth nerve and the sixth nerve, because 5 and 6 can go with the seventh nerve in certain places. In any cranial nerve examination, you are expected to check some cerebellar signs, something like dysterocokinesia or past pointing. Check the reflexes to see whether the patient has hyperreflexia, to see whether there's a long track signs, and see whether there are any brainstem features. Right, so in the brainstem, if you have 6 and 7 together with hemiparesis and cerebellar signs, like I mentioned here, so 6 and 7 cerebellar and corticospinal tract involvement, that would suggest that the lesion is in the brainstem and the etiology is either vascular or demyelination. 5 and 8 going together with the cerebellar signs, that would mean that it's in the CP angle. Most likely lesion is a tumor or an acoustic neuroma. 7 and 8 going together, that would mean that the lesion is in the internal acoustic meatus, and depending on where the lesion is, you can get this hyperacusis and loss of anterior 2/3 of the tongue. Sometimes you can get infection of the geniculate ganglion. This is known as Ramsay-Hunt syndrome with herpes zoster, where you are expected to look for vesicles inside the ear when you have a seventh nerve palsy. And you can have an isolated seventh nerve palsy, then you should always check your parotid to see whether there's any signs of inflammation or any masses. So if none of these are there, that would mean that the patient is having an idiopathic seventh nerve palsy, where you would label the patient as having a Bell's palsy. So you should check for all of these to say that the patient has Bell's palsy. So if those things are not there, only you can say that the patient has Bell's palsy. Sometimes you can get bilateral facial nerve palsy. Again, we don't give bilateral facial nerve palsy to ERPM candidates. And there are few causes like myotonic dystrophy, myasthenia, Guillain-Barré, sarcoidosis. If you have bilateral facial nerve palsy, again, a very difficult case, so we don't give that for you. So Bell's palsy. So we have asked. So I have not shown any other examination, so that you may be able to say that this may be Bell's palsy. But again, but before showing the other examination, you don't, there's no way of telling that this is Bell's palsy, because I have not checked the cerebellum, the long tract, and the other cranial nerve to see that this is an isolated seventh palsy. So if you are confirmed that this is a Bell's palsy, you do not need any other investigation. So Bell's palsy is a clinical diagnosis, but of course, if there are atypical features, this would warrant investigation. So what are the atypical features for Bell's palsy? If you have other cranial nerves, if you have other neurological signs, if you have vesicles in the ear, if you have bilateral facial, if you have systemic signs like fever, neck stiffness, headache, and if the facial nerve lesion is sudden onset. The Bell's palsy is usually gradually onset and it progresses over about 2 to 3 weeks. There is no progression. If it progresses beyond 3 weeks, and if it does not improve in 4 months, again that would suggest that this is atypical for Bell's palsy, and patient would warrant investigation, specifically brain imaging, to see whether there's some other pathology related. So how do you treat Bell's palsy? You give oral steroids for all patients, and there's a severity classification for the facial nerve lesion. You are not expected to know that. So you give antiviral therapy. So steroids you give about prednisolone 60 milligram for about 1 week, and you just stop without tapering. And antiviral therapy you give for severe palsies, you can give acyclovir 400 milligrams 5 times per day for 10 days. And what's most important is you have to prevent corneal injury, because the eye cannot close, the tear film will not get displaced, and the cornea will become dry, and the cornea can get injured. If the cornea gets injured, cornea is avascular and it cannot repair itself, and you will have permanent blindness. So preventing corneal injury is very important. So artificial tears and eye patches with taping is important to make sure that the eyes remain shut. And if the patient has very poor recovery for after all this, you can try, botulinum injections. You can try this procedure called TENS, where you electrically stimulate the facial nerve to see whether it improves. And there may be a place for permanently closing the eye, like sewing the lids shut, that is known as tarsography. So that only you do only if the lesion is very slowly improving. If you do this, most would improve by time. Okay, right. So next is an emergency. Again, you will definitely get one emergency for your OSCE. So this is the emergency. So you can try answering this. Right, so you can have about 2 more minutes. Okay, so definitely you will get an emergency, and most often the emergency may be coupled with an investigation. So it could be coupled with an ECG, it could be coupled with a chest X-ray, or it could be coupled with a ABG. So here we have a 65-year-old man with poorly controlled diabetes, hypertension, and dyslipidemia presented with central tightening chest pain for 3 hours duration. What is the emergency management? So emergency management in any patient would follow the ABCDE approach, because A will kill the patient first, then B, then C, then D, then E. But here specifically you should see if the patient is having poorly controlled diabetes, and you should do a quick glucose check to exclude associated DKA in this patient. So in my patients, when you're having diabetes, you can have DKA concomitantly, as well as sometimes even DKA can present as chest pain, vomiting, or even epigastric pain. So that is important. Then you have to establish IV access. You have to monitor the vitals. We are looking specifically regarding the pulse rate and the blood pressure. The blood pressure can be elevated in these patients with, if this is a hypertensive heart failure with acute coronary syndrome, or blood pressure could be decreased in this patient if the patient is in cardiogenic shock. And you should always see the JVP to see whether the patient is in fluid overload, and you should auscultate the lung basis to see whether the patient is in heart failure. So controlling the patient's symptoms is there in the patient's emergency management, and you can give patient morphine. Sometimes the patient may be vomiting, but morphine itself may predispose the patient to vomiting. So you should give morphine coupled with metoclopramide. So here you give morphine that about 1 milligram per kilogram. Here the weight is not mentioned, but if the weight is mentioned, you should specifically mention the dose, because you're talking about emergencies. You are expected to know the dose that you are giving. So morphine you can give about IV 5 milligrams or subcut 5 milligrams, along with IV metoclopramide 10 milligrams. You give oxygen only if the patient's saturation is less than 94, and you should give stat doses in any patient with suggestive ischemic type chest pain. The stat doses you give is aspirin 300, clopidogrel 300, and atorvastatin 40 milligrams. You do not give this clopidogrel 300 stat dose if the patient is very elderly, like more than 75 years old. There you give only 75 milligrams, and you should order an urgent 12 lead ECG. So here the ABCD approach, glucose check, IV access, morphine, metoclopramide, and the stat doses and ordering for the ECG will give you marks. So next is interpretation of the ECG. So it's very quite straightforward. So first you have to know what constitutes ST elevation. So ST elevation MI would require you to have ST elevations in 2 or more anatomically contiguous leads. So we are looking at territories. So we are looking at either the inferior territory 2, 3 AVF, or the lateral territory 1 AVL, V5, V6, the septal territory V1, V2, anterior territory V2 to V4. So all of these territories may represent ischemia in that specific territory, or ischemia that is uh, not specific to a single territory, or it may be global, because there may be other causes of ST elevation other than ST elevation MI. But here you specifically have ST elevations in 2, 3 and AVF. You here have a small ST elevation here, and you have reciprocal ST depressions in here lead AVL. That is very similar in morphology to this. So whenever you have a STEMI, you should always look for reciprocal changes in the other lead. So inferior reciprocal may be seen in lateral. In anterior, sometimes reciprocal may be seen in inferior. In lateral STEMIs, you may see the reciprocal changes in inferior. But anterior STEMIs may not have reciprocal changes because the reciprocal leads are in the posterior. But posterior STEMIs may have reciprocal changes in the anterior leads, like very deep ST depressions with T inversions in the anterior leads. So if you suspect that, you should do a ECG with posterior leads to demonstrate the posterior STEMI. But here again you can see early Q wave formation in lead 3 and lead 2. So Q waves would mean that this is a transmural infarction, that the cardiac muscle is already getting damaged. So usually more than one small square or 1 millimeter ST elevations in anatomically contiguous leads in 2 or more leads is enough to diagnose a STEMI. So but in lead V2 to V3, the 1 millimeter component may get differed depending on your age, if you are a male, or depending on your sex, if you are a woman or a man. So on only lead V2 to V3, the number of squares may differ, but in all other chest leads and limb leads, only one small square elevation is enough. So you don't need troponins to diagnose STEMIs, but you need troponins to diagnose non-STEMIs and unstable angina. So as soon as you see this, you bring on the specific management. So what is the specific management? If PCI is possible, within 120 minutes, you arrange for the PCI by discussing with the cardiology team. And if PCI is not possible, you consider thrombolysis after excluding contraindications. So the common contraindications would be a recent stroke, ischemic, within the past 3 to 6 months. Any history of ICH would be an absolute contraindication. And of course, if the blood pressure is elevated more than 185 by 110, similar for ischemic stroke, you can consider bringing them down using IV antihypertensives before you start the thrombolytic therapy. So before you give thrombolytics, anticoagulation is a must, and you give IV enoxaparin 30 milligrams. This is typically avoided in patients over 75 years, and you give IV tenecteplase along with that. That is weight based. So if you are less than 60 kilograms, you give 30 mg, and for each 10 kilogram weight gap, you increase by 5 mg. So less than 60 you give 30, 60 to 70 you give 35, 70 to 80 you give 40, 80 to 80, 90 you give 45, and more than 90 kilos you give 50 milligrams. So you need to know that. And again, if the patient is more than 75, you try to give half dose. And after you give this, 15 minutes after, you should again give the patient subcut enoxaparin 1 milligram per kilogram, and this dose plus this dose combined should not exceed 100 milligrams of enoxaparin. So usually you go for 60 to 70 here and 30 here in a well-built man, and you should continue the enoxaparin 12 hourly. The patient is not undergoing PCI. And after you do that, you assess for reperfusion, and sometimes it may be seen immediately, but sometimes it may be late, and you repeat the ECG in 60 to 90 minutes to see whether the patient has reduction of ST elevations by at least half of the ST elevation. Patient should have resolution of pain, and patient will get reperfusion arrhythmias like accelerated idioventricular rhythm. So that part is pretty straightforward. And we have another part that patient becomes increasingly short of breath and hypotensive. So what are the possible causes? So sudden deterioration in acute coronary syndrome patient can happen with many causes, but here specifically we are talking about a inferior STEMI. So inferior STEMIs are known to cause two drastic complications. That is, they can cause heart blocks, they can have bradyarrhythmias, and they can cause right ventricular infarction. So right ventricular infarction is the most likely cause here, but there may be multiple other causes. So STEMIs can give rise to acute mitral regurgitation with your papillary muscle rupture. STEMIs can give rise to ventricular septal defects, giving rise to low blood pressure and shortness of breath with pulmonary edema. STEMIs can give rise to ventricular free wall rupture, where the blood can go into the pericardial sac and can cause cardiac tamponade. And patients can go into cardiogenic shock because of the compromised cardiac function. Patient can go into pulmonary edema because of that. And patients can have bradyarrhythmias, as well as patients can have tachyarrhythmias. So tachyarrhythmias are a major cause of mortality in patients with STEMIs, where the patients can have VT and VF. So all of these could be reasons for sudden deterioration in an acute coronary syndrome patient. And so what to do now? You have to reassess the ABC to see whether the airway breathing circulation is compromised. Re-examine the patient for elevated JVP. So if you have elevated JVP, that to suggest the patient is in right heart failure, and you have to strongly suspect whether the patient has fluid overload, or whether the patient has something like a cardiac tamponade with ventricular free wall rupture. Lung signs would suggest that the patient has pulmonary edema, which again could be due to mitral regurgitation or cardiogenic shock or heart failure. New murmurs, you are specifically looking for MRs, ARs, and VSDs. And you have to repeat the ECG to see whether the patient has a tachyarrhythmia or a bradyarrhythmia, specifically something like a complete heart block. And if you have a murmur, you should always try to do a bedside echo to see whether the patient has some sort of rupture somewhere. And you have to escalate the management depending on the etiology. So if the patient has clear lungs and low blood pressure, and patient is short of breath, possibly because of the low blood pressure, you have to strongly suspect right ventricular infarction. And if you have bad lungs, wet lungs with pulmonary edema, most likely it's due to left heart failure or with cardiogenic shock. And so for left heart failure with cardiogenic shock, your management would be inotropes, diuretics, maybe in smaller doses, and CPAP. But if you give diuretics for a patient with right ventricular infarction, patient will die. So management there would be more fluids. So left ventricular failure, less fluids and diuretics. Right ventricular failure, more fluids and no diuretics. So you have to escalate the management depending on the etiology. And if the patient has a mechanical complication, patient would need emergency surgery to save the life. Right. So last part is communication. So can I have a volunteer? Hello? Is everyone asleep? Hello? Hello, can I have someone? Sanka, why don't you try?
Yes.
Okay, right. So again, communication may be there as a part of a station or maybe even as a full station, but probably it fits there maybe as a part of a station. And so there are few communication scenarios that you should see. And Lumal discussed one, I think, last time regarding explaining a procedure. And breaking bad news is another common situation that you may come across when you are in the ward. Right. So this is the scenario. You can have about 30 seconds to read it, and then you can start, Sanka. Shall we start?
Yes, sir.
Okay, you have 10 minutes. Go.
Good evening, Miss Dilani.
Good evening, doctor.
Are you comfortable to have a conversation right now?
Yes, doctor. Yes.
You are Miss Dilani, right?
Yes, doctor. Yes.
Okay. So we did some investigations on your biopsy, and uh, the results, we found out that you are diagnosed with a condition called non-Hodgkin lymphoma. What do you know about this?
Oh, I don't have any clue on what that is, doctor. I just came with fever, and I have been here for about 1 week or so, and you have done multiple tests on me, and now you tell that I have some weird condition. What is this, doctor?
Yeah, so don't worry. So this is a condition that people have, and so do you want to be alone, or you want someone with you?
No, doctor. I think my mother will come in a while, but I want to know what's happening, doctor. Yeah, please go on.
Okay, so I'm sorry to say that this is a form of blood cancer that you have.
What? Cancer? Oh, are you sure, doctor?
So as far as the results go, it is a form of cancer, but we can start treatment right away, and we have the necessary consultants and the necessary facilities for the treatment. So I'm assuring you that you don't have to worry about this.
Your doctor. What's gonna happen to me?
Don't worry, Mrs. Dilani. Many patients, they have this condition, and with the treatment, they all get better.
It's a lot to take in, doctor.
It's
I'm
okay.
having.
You can take your time. You can ask me anything.
I'm having high hopes about my life, doctor. Now you tell me that I'm having cancer. How can I take this, doctor? I just had fever, no? How can it be cancer?
So like
Hey, doctor.
Miss Dilani, like again, I'm telling you, like the prognosis in this condition, it's usually okay. And we don't know, like even though we diagnose you with this cancer, we don't know the extent of it and all. So like right now, what you need to be is to have a good positive mindset. We'll do some more investigations and so we'll see what will happen. Okay.
No, are you sure, doctor? Has this been confirmed?
Yes.
Okay. So, uh, does your boss is also aware of this? Can I speak to him?
Yes. So what we'll do is I will write a consultation to my boss and we can proceed over there as well.
Hmm. So is it, where is it, doctor? Has it spread? Uh, what sort of condition I'm in right now?
So for the confirmation, we need to do another biopsy.
Okay.
And with that, I can tell you more information. But for right now, uh, what I can say is you are diagnosed with non-Hodgkin's lymphoma.
Hmm.
We'll do some scans in the future and we can manage the treatment plan accordingly with what comes with the scans and all.
Oh. So what sort of treatment is there for this, doctor? Is it curable?
So the prognosis with treatment is very good in the condition that you have. So we'll have to do some treatment. There's a treatment called chemotherapy that we can do here. So with
I
chemotherapy,
I lose all my hair, right?
but this is the thing, Mrs. Dilani. So there's a thing called risk to benefit, right? So if you don't do this non-Hodgkin lymphoma that you have will spread, and the prognosis then will be not that good. But if we go through the chemotherapy and go through the management, we can have a better prognosis and you will have a better life.
God. Now, doctor, now you tell me that I have cancer and I had to go chemotherapy. This is unbearable, doctor. My wedding is next month. Now, how can I go through with this, doctor? What do you suggest that I should do, doctor?
So like with things like this, the earlier the better. So your partner, he will understand about this condition. So if we start the treatment early, the prognosis will be better. So I would like to speak to your partner as well. And we can speak to both of you. I can speak to both of you. And the therapy usually it responds well. But you can take some time to process this. And if you have both of you have any concerns, I'm here to address it.
But this chemotherapy is very, toxic to the body, no, doctor? Will I be able to have children after, doctor?
Uh, Okay, so Mrs. Diladi, so what we can do is before we start the chemotherapy procedure, we can take some eggs from you and we can preserve it. So when the chemotherapy treatment is done and when you are at a better state, then we can think about having children. How about that, Mrs. Dilani?
So, if you don't do that, it's going to affect my fertility, it seems, right?
Most probably will.
Okay, right. So, I have heard about this thing called, transplants for, blood cancers. Is that a possibility here, doctor?
Uh, so I'm not sure about that, sir.
Okay, right. So,
So I think yes.
okay. Now, but you to no, I only had fever, no, and this, I had some nodes in my neck, and whatever you have done after now, it has not worked, and you want me to go ahead with chemotherapy. Is there anything else that you can do for this?
Uh, so the reason that everything else has failed with your fever is because you have an underlying condition, which is this non-Hodgkin lymphoma. That's why we had to take a biopsy from the cervical area of yours. That's the reason why you had fever of unknown origin.
Hmm. Okay, doctor. Right. So, because it's a very big decision, doctor, you want to make me take the decision right now?
No, no, you can take your time. You can think about this. You can go speak to your spouse as well. Then you can come back to me.
Right. Is there any way of getting a second opinion, doctor?
Yes, so what we can do is I can send another consultation to my senior and we can get a second opinion from him as well. But when you make the decision, you can come back to us and we'll proceed with the management.
Okay, doctor. Right. Okay, doctor. Thank you. Your time is up. Right. Okay. So, if you get a role-playing scenario, most likely, the examiner or the one who role plays it would be a surrogate, right? So you should be prepared for angry patients. Patients may cry, or all sorts of things can happen, like the real life scenario. So this is a very common situation that you get about breaking a bad news. So you did some things good, and some things could have been more improved. So whenever you have encounter a patient where you should break bad news, you should always practice the spikes protocol, right? So here now, first, you introduce yourself well, okay? Then you could have told that I'm one of the doctors looking after you. I want to speak to you. Is it a good time to speak? Is this a good place? Whether you need any someone else before this, and that would suggest that putting that at the beginning would prepare the patient to take a hit. To think that something bad may be coming, right? And then patient has been having fever, you have done biopsies and all that. A better way would have been, how to ask how you are doing up to now, rather than just rushing on to saying we have this biopsy, you have lymphoma and all that, right? Just see whether how the patient is doing and whether the patient is in pain, any discomfort, before you divulge this big news. And then rather than going straight ahead for the lymphoma, you can ask maybe, what do you know about what we have done for you? And then the patient would come that out that whether you had fever and you have given antibiotics, and they have taken some note out, and you have heard that you have got the report, and I want to know what the report is. Then you can see at what level where you can give this diagnosis. And so then only you should ask the patient that we have got the report. Do you want to know what's in the report? Then you invite the patient and obtains the patient permission to continue. Then the patient would say, that I want to know what is in the report. Then you provide information. So up to that point would have been improved, and how you provided the information uh, was a little better, but you could have told beginning with the maybe like something like, I'm afraid I have bad news, your report has turns out to be having cancer, right? So you should give the diagnosis straight away rather than beating around the bush, but you should just cushion it in a way that patient will take the hit a little less. And then you should provide information. Maybe you could have, uh, gone into more detail regarding, what lymph nodes are, like how blood cells are in those lymph nodes, and because you have a problem or a overgrowth of tissue in that node, that's why you got lymph nodes there, and that's how you got this blood cancer known as a non-Hodgkin lymphoma. So non-Hodgkin lymphoma is a very wide variety. Sometimes you can have good prognosis and sometimes you can have bad prognosis. But you should not give the patient false hope. At the same time, you should give the patient some hope. So it should be something a balance in between. And you should, when you are giving chunks of information, you should always periodically check for comprehension. So as I told you, the patients can cry when you break bad news, patients may be in denial, patients may be angry, and you should offer emotional support and uh, don't keep speaking when the patient is either crying or having needing some time to them. So patting on the shoulder or maybe offering tissues may not be that culturally acceptable in Sri Lanka, but you should give the patient time to deal with the emotions and then ask whether you want me to continue, and if the patient says yes or has no objection, then you can go continuing on that, right? So you have to respond empathically. And the patient kept asking about, second opinions and asking about seniors, and of course you are the most junior person here, and then you should tell, like you mentioned about, arranging a meeting with my seniors along with the family to discuss more regarding the further treatment options. Then family patients had many concerns. Patient was about to get married, and you were talking about chemotherapy, about how toxic it is, and about fertility issues and losing hair and all that. So that again, about chemotherapy, about toxic drugs that you're going to give, about the types and modes of management. You could have uh, you know uh, packaged it the more nicer way, right? And you had some good points. You always gave time for the patient. You told me that you can think about it and come back again. And and you should always say that we can have a next meeting and you can plan for the next meeting. And then at the end of the discussion, you should always see whether the patient understood what you told, and then summarize it and review it again to see whether the patient understood and whether both of you are on the same plate regarding what should happen next, right? So it's a little bit of a difficult scenario because you are not quite sure on what to do for non-Hodgkin's lymphoma, but lymphoma is a very common problem in young females, and it can happen, or maybe even a cancer could be given as a breaking bad news in these patients, right? So if you have a friend, you can get in groups of two and start practicing these communication scenarios, and so that if such a situation is there, you can score very well, because it's just talking. There's nothing much to uh, remember there, right? It's about practicing and talking, right? Okay. So that brings us to the end of the discussion. Any questions you have? No? All right then. Okay. So we'll wind up, and if you have any questions, you can post in the group. I think we'll probably restream or upload this content while after this is done. Right. Okay. Then until we meet again. Right. Good luck.
Thank
Good
you,
night.
sir. Good night, sir.
So good